To thank my colleagues, organizers, who gave me this opportunity to present you therapeutic innovations in asthma. Throughout this, we will try throughout this work to analyze this work by using 4 items. First of all, we review the role of epithelium and epithelial cytokines in airway remodeling. Second, we underline the principal challenges to identify appropriate patients for biologic therapies, and we highlight new and existing targeted treatment. And finally, we evoke the concept of remission in asthma. Asthma, as known, is substantial economic burden worldwide. Asthma affects over 3,100,000 people worldwide, and 19% increase worldwide from 2007 to 2017, and more than 1,300 people died per day. And what is the economic burden in asthma? As we see in US, for instance, the direct medical cost, absenteeism, other cost, the total is $22 billion. In Europe, $72 billion. What about the role of, or how the epithelium orchestrate or drive the airway remodeling? This is a good article published by Gilda Barici. We take into account the development in genetic sequencing and imaging techniques which have advanced our understanding of the roles of the epithelium and epithelial cells in airway or driving airway remodeling. As we know, the development of asthma, its progression, associated physiological decline in lung function, depend on a number of genetic, environment, and other or related other factors that include age. These risk factors regulate the cluster between epithelium, innate and adaptive immunity, and mesenchymal stroma that contribute to airway remodeling. We know that there is 3 integrated and dynamic processes to drive airway remodeling. First of all, initiation by epithelial cells and amplification of immune cells and mesenchymal effector functions. As we know, the primary airway epithelium is the primary interface between environment and the lung. When triggered by allergens or microbes, the epithelial cells responded by secreting soluble factors to recruit immune cells. And the amplification of the immune response involved by macrophages, dendritic cells, neutrophils, mast cells, eosinophils, and lymphocytes. These provoke what we call airway remodeling. As a result, this is the airway remodeling. This one is the healthy airways. What about epithelial cytokines in airway remodeling? We have TSLP, thymic stromal lymphopoietin, which is elevated in asthma patients and correlate with severity. Interleukin 33, which is elevated in asthma too and correlate with severity, and interleukin 25, which correlate with severity. These cytokines are known as alarmins, which are central in asthma physiopathology. They mediate both innate and adaptive immunity response, generating Th2 and T non-H2 inflammation, as well as structural changes. The combination of inflammatory and structural changes in airway remodeling, which may occur in parallel, produce a fixed airway obstruction. Th2 inflammation contributes to airway remodeling in most patients with severe asthma. Conversely, the contribution of non-Th2 inflammation to airway remodeling remains to be fully clarified. How to identify appropriate patients? This good article, Managing Difficult to Treat Asthma, is the starting point to identify this minority who persist poorly controlled. This is the definition of uncontrolled asthma, difficult to treat asthma, and severe asthma. As we know, the majority, as we see here, of patients are controlled by conventional treatment. However, minority will continue to have poor control despite treatment at steps 4 or 5 of the GINA guidelines. And these are labeled difficult to treat asthma, and severe asthma is a subtype of DTA. This is a great survey in Netherlands published by Hooking, which identified this minority. But it is known that we need cohort studies with a lot of patients, 1 year or 2 years, to identify this patient. According to the Forum Respiratory or Biologics, there are key challenges in identifying patients with severe asthma. Patient referral to specialized care, to confirm diagnosis of severe asthma, and phenotyping and phenotyping via treatable traits to identify patients and to guide treatment decisions. What about appropriate referral of patients with severe asthma to specialized center? As we know, because of the complexity of severe asthma and heterogeneity, we need an organization to manage this by the creation of specialized centers. And we need a multidisciplinary team of physicians, GPs, nurses focused on asthma, and availability to perform tests other than lung function. An example, functional FeNO and induced sputum analysis. What can specialists do to confirm diagnosis of severe asthma? They improve the patient's adherence to ICs, and they check and correct the inhaler technique. They identify and eliminate exposure to risk factors and triggers, and assess and treat coexisting conditions, notably or obstructive sleep apnea or ABPA. Someone of this patient remains poorly controlled. These patients could be candidates for targeted treatment. What about phenotyping? This is the classification of asthma phenotype and disability. We talk about the late onset eosinophilic asthma and allergic asthma in Th2, and very late onset asthma frequent in female and obesity in non-Th2. In contrast to type 2 high asthma inflammation, less is known about mechanism in type low asthma. Clinicians should establish clinical and inflammatory phenotypes by measurements to sputum inflammatory cells, blood eosinophil count, and FeNO, and coexisting conditions to diagnose type 2 high asthma, according to literature. Blood eosinophil more than 150 sols, FeNO more than 25 ppb, and sputum eosinophil more than 2%. Diagnosing to type 2 no or type 2 low asthma is less. We conclude that type 2 high asthma is the most accounted for severe asthma. It represents 70%. What about suitable trait? This is the new concept by European Respiratory Forum, Biologics, which talk about clinical phenotype, the traits, biomarker, biological response, pathogen process, and the treatable trait, I mean geographic target, phenotyping the type, and identifying the subtype, disease as severe asthma. The objective, the aim of treatable traits is to apply personalized medicine to each individual to improve outcomes. This is a good study in Australia assessing clinical impact in an analysis of treatable traits in severe asthma using the Australian severe asthma database registry. From 24 identified traits, 10 were classified with an increased risk of future exacerbation risk. You can cite exacerbation prone, vocal dysfunction, and depression. How new and existing targeted therapy? The combination of clinical inflammatory and rheumatic phenotypes permit the optimal personalized treatment or approach to the treatment. The current management to severe asthma is this, according to the European Respiratory Biological Forum in 2018. Strategies for eliminating the use of LCS is medicine that we emphasize about biologic therapies. This interesting article, this is a medicine for severe asthma, based on treatable traits that are specific to identify the distinct phenotypes and to the types of patients in the search for new therapeutic. This is an example, for instance, allergic, or which needs to minimize allergic exposure or to treat by anti-IgE. What about biologic? There are 6 biologics: omalizumab, mepolizumab, benralizumab, resilimumab, dupilumab, and tezepelumab. This is the role in molecular level of biologic therapies for severe asthma that target cytokines and downstream mediators may ameliorate airway remodeling, as we see here, tezepelumab, antagonist of TSLP, for instance. This is the effect of biologics, as we see here in this table. And this is the targeted treatments of biologics to analyze exacerbation, LCS dose reduction, LCS withdrawal, symptom, and quality of life. What about the concept of remission? This is a good rostrum published by Menzies Go et al. An expert consensus framework for asthma remission as a treatment goal. With novel therapies in development, there is an opportunity to consider asthma remission as a treatment goal. This is a hierarchy of possible outcomes in response: clinical remission and complete remission. The cure in response to treatment is hypothetical at present time. This is the criteria to clinical remission on treatment and off treatment, the complete remission on treatment and off treatment. If we resume this, we notice that there are, in reality, 3 criteria. The absence of exacerbation, withdrawal of systemic corticosteroid use, and asthma symptom control. The 4th criteria, improvement in lung function, remains under debate as some patients with long disease duration and fixed effort obstruction are unable to improve or normalize their lung function. Finally, this is a good paper of Andrew Lindsay's Go to evaluate the proportion of patients reaching remission with benralizumab. The efficacy and safety were demonstrated in previous pivotal phase 3 trials, Sirocco, Karima, and Zonda. This analysis applied a composite remission definition to characterize individual response to benralizumab after 6 and 12 months. This is the asthma questionnaire, control questionnaire 6 score, less than 1.5. And pre-bronchodilator FIV1 increased more than 100 milliliter and 0 LCS use and 0 exacerbations. This is the result. Patient achieving no exacerbations, no LCS, as we see in the Sirocco and Karima Zonda 6 months and 12 months. In the trial of Zonda, there is also achievement of no exacerbation to compare by the placebo. In conclusion, we can say that Th2 inflammation to airway remodeling in most patients with severe asthma and patient referral to specialized care and phenotyping difficult to treat asthma patients reinforce the severe asthma identification. Evidence indicates that biologic therapies can improve not only clinical symptoms but only airway remodeling severe asthma. Remission is an ambitious treatment goal that it is one worth striving for. Thank you for your attention.